professionals that are very passionate about making a difference in where they're working. Fostering innovation, problem solving through systems thinking, making sure that we develop healthcare leaders, professionals, clinicians, and students. So really going across the gamut of everybody working in healthcare so that we're taking in all viewpoints when working on improvements. A little bit more about SHS. This is put on by the young professionals community, but there are 6 different communities within SHS that could relate to you that you might want to get more involved in, and those involve education, academics, clinical. So if you're coming from a nurse background or any type of clinical background, students, young professionals, which is a few of us on the call today, and then experienced professionals. So if you're interested in joining one of those practices, feel free to reach out to us and we'll either put you in contact with who that is, or you can go on the website ise.org/SHS. Whew, that's hard to say. Okay. So like I said, this is the third installment of these think tanks. So this is just a link to the 2 previous ones where you can go back and review discussions that have been done. They've all been pretty great and in a lot of different perspectives, so check those out. We'll also be recording this and send it out on Monday in case there's anything you want to go back and look at. So today's purpose and agenda of the think tank, same as all the other times, to have a collaborative discussion on the impacts of COVID-19. And today, what we've heard from previous discussions is we want to focus on best practices and lessons learned. So we sent a call out for people willing to present what they've been doing at their facilities, and we actually got a lot of feedback. So thank you everybody who has is willing to share what they've been working on. So today we have a couple of different speakers, and I have their PowerPoints already pulled up in this slide. As always, since this is a think tank, you can message in the chat or raise your hand and unmute yourself if you have questions at any time, and either one of them will answer, or hopefully someone else on the call can answer if they can't. So with that, I'm going to kick it off to Paige, and then we'll go to Nora, then Josh, then have a little update from Joyce. So that's going to be kind of the layout, but like I said, you guys can contribute at any time by either raising your hand or unmuting yourself.
Great.
So
well,
that,
this is Paige Etzler. I just want to make sure everyone can hear me fine.
Yep.
So, okay, great. So I'm going to give you a little bit about the experience that I recently went through. Prior to all this media hype and our quarantines and our self-isolation, many of you heard about the Princess Cruise Line passengers and the fact that the passengers had positive patients within those cruise ships, and that there was this mandatory quarantine. Well, because those cruise ships went through some international waters, what we had to do is we had to federally quarantine them. So I am part of and you can, next slide, go ahead. Okay, so I'll give you a little bit of my background. So I'm a registered nurse. I have a 4-year degree in registered nursing. My doctorate is in healthcare administration, where I did really focused with a strong criminal justice background. So my dissertation was actually on criminal profiling. I have an MBA. I have a master's in science in criminal justice, as well as forensic toxicology and blood serology and forensic DNA. And then I'm also a fellow in the American College of Healthcare Executives. So my background, I've been a healthcare executive. I've been a director over flight and trauma services at Virginia Commonwealth University, worked at various emergency departments clinically for 30 plus years. So emergency preparedness, I was also associate professor of emergency medicine. And so that was basically my specialty. So let's talk about the government services. So I work under Department of Health and Human Services. So frequently you hear about the DHHS. And within DHHS is the National Disaster Medical Systems, NDMS. And then underneath National Disaster Medical Systems, my specific team is the Disaster Mortuary Operational Response Team, which we DMORT. And so many would say, well, why do you have a nurse within DMORT? Well, DMORT is actually comprised of we have dentists, we have radiologists, we have a lot of morticians, forensic and DNA experts. And so we've been deployed at various 9/11, and I personally worked in the morgue following Hurricane Katrina. So it's really a pool of forensic experts, and we are deployed when the death capacity exceeds that of what the local or state authorities can handle. Now, we were not deployed for death. We were deployed to assist DMAT. DMAT is Disaster Medical Assistance Team. And so we supported them in this federal quarantine. Next slide. So basically we were given like 2 hours notice to be at the airport. We did not know what we were going to be expecting. There was no facilities set up for this. We just know we needed to report at Fort Dobbins. We worked very closely with the CDC, with public health, and again, the disaster medical assistance teams. And what we were tasked to do within a 1 day's time is to actually set up a compound for to be able to address all these patients. And you might want to I think we'll go back. What was the slide? Is there a slide previous? Right after this one. There you go. And so the compound you can see there to the right. And so because we did it so quickly, a key focus, and you hear this with normal hospital operations, but during a disaster, it's even more important, is to communicate internally and externally. So if you see on the right, these passengers were kept in Marine barracks, Air Force barracks, and they were separated by a fence line. And when a hot zone was within that fence line, we had to be in our full PPE. And then outside of the fence line, you had to be behind the fence 6 feet. Well, they were not happy. They were angry. They were exhausted. They were tired. The flight that came in was at 3 a.m. So they were cold. Many of them were fearful. And because the information was limited or haphazard, they became very angry and disgruntled. So our task was actually to start serving meals. We had to serve 274 meals. So they came in 150 one night. Then we had 2 more planes of people coming in. For the hot zone, initially, I was the primary nurse, and I was supported by 4 additional roles, 2 of which were morticians. One was an EMT, and one was a law enforcement officer. And we had to do vital signs on all of these patients and serve their meals. So what you see pictures here is if you communicate internally and effectively, what will happen is you will streamline your processes. So prior to having a system of communication, when we were handling meals, every person used that as protected time to ask us a million different questions. And it took 2.5 hours to be able to see all these patients. What we started doing, what was called walking the fence line. And by walking the fence line, allowed people to know that we were always there and they could come to the fence line to ask any questions. We would follow up with them immediately. And we were continually keeping those lines of communication open. So because of that, opening that fence line and that communication, we were able to decrease our rounding time on all these patients from 2.5 to 3 hours down to less than 30 minutes. And what we noticed was after the communication, we weren't stopped at every single room. And that's what we had to do. We had to go to every single patient's or passenger's room to be able to do vital checks and pass meals and all their questions were answered. So these are pictures of what at the bottom is one of the cruise ship passengers who had towards the end, she said it was a fabulous experience. We became very good friends with all of them. And then in the upper left corner, you see the letters. So these are letters from the community that we would bring into the hot zone to let them, most of the letters said, "You're not forgotten. We're here supporting you. Hang in there. We know it's difficult." We were bringing in games, puzzles, doing anything to try to make their stay So just similar to hospitals and customer service in facilities, is making sure they're meeting their needs the best as possible. And one of those needs was communication. Okay, next slide. Okay, so process consistency and accountability. So I think the to the left, you'll see that's public health. So even though we distributed so many meals, and as soon as we were done with one set of meals, we were starting with lunch, and then we were starting with dinner. But we had public health coming in and checking the temperature, checking the presentation, making sure the meals were appropriate. And we had numerous patients who had special dietary needs, and we still had to meet those dietary needs. So we had like gluten-free, vegetarian, vegan. We had someone who could only eat high protein. So those meals had to make sure that they were passing an inspection before they ever came into the hot zone. So we had that whole regulatory process in place, even though we were in disaster mode, to ensure that we were meeting those dietary needs. And now on the bottom is a colleague of mine and myself behind the hot zone. And when you are working so closely and working so frequently with these people, you've got to have I call it the wingman attitude. And especially when you're in PPE in the hot zone with concerned about COVID-19, everybody needs to be watching everybody else. So many times if we had a break in our PPE, we were not aware of it. It was someone else telling us, you know what, your glove is ripped, or your arm has a tear in it. So it was a partnership, but it was always maintaining the standards, and we never lessened on any of the processes. No matter how many patients we received, we always maintained that standard. Next slide. Okay, role clarity. So during this mission, we had various roles. We had morticians, EMTs, law enforcement officers, nurses, physicians. What was interesting was we did not necessarily work based on our professional role. We worked based on the role we were assigned during the emergency. And this would go the same for hospitals. So we had teams that were deployed specifically for their skills in putting up mass tents and headquarters and processes. We had a meal distribution team. We had a medical team. We had a team that was just runners. We had someone who was a liaison who always was at the fence line communicating with the passengers. And so our professional role, wasn't always what we were supposed to do as the team, but what we did was we all had a common goal. And sometimes we would rotate, and by rotating, you never had one role that was over capacity while you were underutilizing another role. So there was constantly change, and making sure if one person's done, everybody's done, and everybody works until everybody's done. Next slide. Okay, so assess, revise, and hand off. So these pictures, the first picture in the upper left-hand corner, this was actually taken, this was close to 3 a.m. We were all waiting for the flight to arrive, which was very kind of eerie because we didn't know what we were expecting. And we did a debrief. Everyone knew their role, what the process was, what they were supposed to be accomplishing. And the picture below that was the flight landing at Dobbins in the air base. And you can see we were all in our PPE, and we were having to bring these patients out of the airplane, ask them their medical history, screen them, have to assign them rooms, transport them to the barracks, and then assist them to get to the rooms. So very similar to coming into an emergency department, appropriate bed utilization, admission, and getting them to the rooms, but just in a different location. And then the picture you see to the right was after one of our first meal distributions, and that was our team right there. And we were exhausted. It was very hot. We were sweaty in the PPE. But after every meal, we gathered and we assessed what could we have done better and what were some opportunities. We never made changes unless the team agreed upon the changes. And what we found was handoff on night shift. Originally, night shift would come and they would think they were implementing something that would be better, but it was actually creating redundancy for days. So we had to have that consistent flow of how we were going to communicate to patients, and the processes we used flow from days to nights and back to days, and no revisions were made with an appropriate handoff and agreement with the team. And again, that's how we got from 2.5 hours of trying to meet everyone's meals, which originally they were disgruntled and angry, meals were coming in cold, to less than 30 minutes. Next slide. And then attitude is everything. I don't know if you can play this video, but it's on the PowerPoint. But this is a ServPro worker, and he was jamming every single day. He was in the hot zone, dancing, no headphones, no music, but dancing constantly. And I was actually filming him. I was out. I had just finished serving. But just to watch him, it changed the attitude. And everybody who saw him, even the passengers, he improved the attitude. So what's interesting, when you work with the government and you're deployed, if you have a bad attitude, you are sent home. It is never tolerated. And frequently, or usually every deployment I've been on, there's at least one person, for whatever reason, and it's usually attitude, is sent home. Now, I think it's something to think about, because we always, no matter how difficult things got and how frightening things got, we all had a positive attitude, and we became very, very close during this period of time. In nursing, many times we allow infectious negative attitudes to surround the entire unit and decrease the morale and decrease the work attitude of everyone. And so it's a comparison that I look at with the government, that is not tolerated. And there's always positives to look at. During my deployment, I had a terrifying incident. It was one of the police officers and I were distributing meals. We were in an elevator. There was nobody in the barracks, and the elevator shut down. We could not get out. There were no way to communicate. Because we're in a hot zone, we had no phones. It was terrifying. When we finally came out, though, we laughed about it. We immediately established a safety protocol and a process to make sure that whoever went in an elevator, someone was aware they were in there. So again, attitude is critical during any processes or any work environment, but especially during a disaster. And the next slide. So this is a picture of these passengers came in. Originally, we had food thrown at us. We had people screaming at us, yelling at us, calling us names, angry at everything. And towards the end, they became very close friends to many of us. And at the point that each state, the governors would say, we're releasing, example, Maryland, you can come back to your state, and they would all fly separately and have their transportation arranged through the state. And so as the states left, we had applause and cheered them, and they would be waving and blowing us kisses. And so it makes me think, equating it to a hospital experience, it's really not how you come into an organization, because you come into the ER and you're frightened and not knowing what you're going to expect, but it's really how you leave. So if you were to survey every one of those passengers, I can't imagine us having a negative survey, because every single passenger told us how pleased, how happy they were, what unfortunate experience turned out to be something that they'll never forget. The same thing would go for any patient that goes into an organization. It's how they leave, they remember. So any questions? The focus would be communicate, work as a team, role clarity, and always assess, reassess. And it's how you leave. What's that lasting impression you give to people as they leave your organization, your facility, or situation you're in?
Great. Thanks, Paige. That was awesome. Do we have any questions specifically for Paige before we go to Nora?
Well, thank you for having me.
All right, thanks, Paige.
All right, I'm going to pass this off to Nora. She's going to talk about Bay Pines VA healthcare system.
And Nora, can you unmute yourself on the WebEx? I can't seem to find which one you might be. Or if you don't know how, you can raise your hand in there. Also. Is Nora on? Send the invite.
We can skip to Josh while we figure that out.
Yeah, that's fine.
All right.
All right, let me
Josh, are you ready? Off mute.
I just unmuted him.
Yeah, I'm here. Can you guys hear me? So I'm Josh Harung. I'm an improvement advisor with UW Health in Madison, Wisconsin, not to be confused with University of Washington. So just talking through some of our new facility stand-up planning that we've been doing for the last couple of weeks or so. So big picture, UW Health, just at a glance, we're located in Madison, Wisconsin. Serve patients all across mainly south central Wisconsin, parts of northern Illinois, and then a little bit into Iowa. Next page. Next slide, please. So, in the Madison area, we have a few different main hospital areas. In the bottom center, we have our main hospital and clinic area. We also have a large children's hospital. And then on the east side of town, we have a newer community-based hospital that has a lot smaller beds. So just under 700 beds in total across the city, and just in the surrounding areas. We are a smaller Midwestern city that serves probably just under 1 million individuals. Next page, please. So I think we've all seen some variety of this chart. We know just from New York or Italy and elsewhere in the world that surges are hitting healthcare systems, and there's a lot larger need than capacity to care for a lot of the patients. So probably a little over a month ago, modeling estimates had Wisconsin and our area peaking probably towards the end of April, beginning of May, sometime in that area. I don't have the numbers in front of me, but from an overall systems perspective, we knew that we needed to start opening up capacity to potentially serve some surge patients. Next slide. So as with a lot of areas, this is just some of our existing facilities, a very just simple mock-up. So some of the ways that we started working through some of this was looking at creating some temporary facility space within our existing facility. So example here, just be the light blue on top of the dark blue areas. Some of this was just existing space within our hospitals. So surgery areas, operating room areas, things of that nature. But we knew based off of some of the modeling out there, as well as what other systems are seeing across the country, is that surge volume is much more greater than what we could even facilitate from a temporary perspective. So next slide, please. So one of the questions that got brought up early by our progressive planning group is, what if we can modify really an existing one of our facilities, so a procedure area, a outpatient surgery center area, and potentially decant some patients who only really need a lower level of care. These aren't really necessarily COVID patients or people that are suffering really ICU related items, but just people that aren't really impacted by COVID. Can we get them out of our main hospitals into a lower level facility, take care of them for a couple more days before they can go home for discharge? So that was the initial question that we looked at. We identified one of our procedure centers and wanted to be able to figure out how we could turn that into a facility soon. So next slide, please. So really rough timeline here. We started this planning probably beginning middle of March, almost a month ago. We got some marching directions that we had to be able to activate at any time within really that Wisconsin peak period. So one of the concerns initially that we started with was, we could be turning this facility on as an inpatient area anytime within the next week. Now, if you are working healthcare, like I think everyone on this phone, you're going to recognize that this is probably maybe like a 6-month project that would normally take that time. And it's really getting crushed down into a week or two worth of time. So really our questions were, how do we really do this fast and do this well? So go next slide, please. So a lot of the driving questions that we had, our marching orders were really to, once we get some notification, how do we activate this area in a 24-hour period? So how do we get the staff there? How do we get all the supplies there? How do we start transporting patients there? What is the care delivery going to look like there? Do we have diagnostic services there that we might need to utilize, or would we have to do some transferring of medications from our main facility to this facility? How do we discharge patients was another big question out there. And then what if we need to move someone back to that higher level of care? So maybe they were doing well, but they need to go back to our main hospital for continued diagnostics. So really needed to be able to answer all that, set all that up in a very short amount of time. So next slide. So one of the first things that we did just for success, we really had set up some structure. So we had everyone going up through our main incident command structure, which follows the Hicks model, what a lot of healthcare facilities are doing. We identified a clinical work group, facilities work group, an information systems work group, and then myself and another improvement advisor on our team really helped facilitate a lot of the clinical work group development and some communication between the teams here. So overall, there was about 30 different functional areas, all really needing to work together to accomplish a lot of this work. And I think you can go into the next slide there, Allie. So step 2 is really clarifying some of our needs and deliverables in a very short period of time. From a clinical work group, we really needed to figure out who the best types of patients were going to be that could move to a lower level of care, how we'd really move those individuals. So working with local ambulance services, what does the process look like from an IT perspective to move someone there. Once they're there, what does the medication delivery look like? So we have a pharmacy on site, but what happens if it's something that might need to be compounded at our university hospital and brought over? From a facilities perspective, all the rooms at the procedure center weren't really set up for inpatient long-term. So what types of tools and supplies need to be there? So getting supplies there. And then from an information systems perspective, what does the EHR build really look like? So moving someone to a new location, setting up telephones, setting up call systems, things of that nature, so that as patients are added onto this facility, what does that look like? How do we really make sure we have a safe environment for them? So next slide, please. So step 3 of a lot of this work was really organize our team, set up a really fast-moving environment. We had a once-a-day clinical work group meeting with about 20 individuals walking through this, and a lot of this was done virtually to help facilitate with our social distancing guidelines. So a once-a-day clinical work group meeting. We had to help organize all this, a once-a-day huddle with our leadership group, reporting up through incident command and team leads, just to really prioritize, organize a lot of this work, build a lot of communication, and figure out what our plans are going to be for the next day. And then we've also been having a once-a-day huddle just with my peer and clinical lead to hash out what we had done for the day, what does the agenda need to look like the next morning, things of that nature. So it was really almost like a fast-moving rapid improvement event or value stream mapping event that got compressed into a very small amount of time. Next slide. So really working through a lot of this work. Obviously, with any type of project, we are going to find action items, issues that come up. So really learning to prioritize and manage a lot of our work. So we had a standing action item log that we could bring up in meetings. talk through, really prioritize the critical items, look at some medium items, and then some low priority items, and then really assign those out to people day to day to make sure that they're getting done in a fast manner. We also did a lot of issues and gap analyses. From a safety perspective, just from a perspective of if we're transferring someone, what's an issue that might come up from a communication standpoint, and how do we minimize any potential safety issues? So almost like a really de facto type of FMEA model. So next slide, please. Once identifying a lot of the action items, we really developed a lot of processes. So I think we started up with 5 standard processes for this. One was being how we activate. So how do we find the staff to, once we get a 24-hour notice, how do we get the staff there in 24 hours, whether they're clinical support staff, providers, some of these supplies that are kept at our central warehouse, things of that nature. Then how would we really transfer the patient? So this one on here is really more of a process map that we walk through as a team, laid out what the process should look like, ran through that an iteration with everyone who would be involved, identified roles and responsibilities for each action item within a patient transfer process, really made sure everyone was really comfortable with where things were before we would, in theory, start moving to patients. So next slide. So that was really our high level outputs that we've been doing. A lot of this has been planning, and over probably just a 2 or 3 week period, we were able to stand up several different processes just for care delivery in a matter of a lot shorter time than we thought it would be. Just some lessons learned is a lot of people are probably learning just from some of the COVID work is trying to learn to embrace the uncomfortable. We know that if we need to open up a facility, we'd probably be having a lot of surge patients, and one of our physicians has been referring to this as the post-apocalyptic dystopian wasteland. So we need to embrace some uncomfortable circumstances and not really try to be perfect. Just make sure we have a safe environment for some of these patient transfers. Once we get there, we can always iron out the wrinkles later. Really working within teams. We've also found it was just certainly helpful to be very transparent and timely with action items and meeting minutes. So really setting up that structure, being very open with everyone involved with the team. Like I mentioned, we had around 40 people involved with this. So open transparency, a lot of communication, getting the frontline staff involved as much as possible really helped with our planning efforts. And then really adopting just almost like a sprint methodology from a day-to-day basis. So showing what we've done, what we plan to do, where you need help on a day-to-day basis really help keep things going. Fortunately, so far, Wisconsin overall has seen a lot less COVID patient volumes than we predicted. So we are really in the standby mode, but from a planning perspective, we were able to stand this up and get a plan together. So should we run into something in the next couple of weeks, we can always activate the facility. So that's really a high level what we've been planning on just as a way to open up some facility space. So if anyone has any questions or is just interested in feedback on how we've done virtual teams or developed cross-functional teams in a short amount of time, feel free to ask.
I have a question, Josh. What is like in your team communications when you're doing, I'm assuming, are you doing virtual like webinars to update your teams if they're different, you know, I don't know what I'm saying. I'm trying to figure out how are you getting everybody together? Is it virtually? Is it in one Zoom?
Yeah, so this is, and I'm sure other PI groups are dealing with this too, is we had to stand a lot of this up virtually. So a lot of the team members, pretty much all of them that I worked with, I hadn't never met in person. So everything, or probably about 90 to 95% of it, was all virtual meetings, without going to the hospital, without facilitating some of the stuff in person, was a unique learning experience. So really trying to be a lot more, communicate a lot more than I've been used to within these groups. Does that answer your question, Allie?
Yeah.
I think one thing that would be good, Allie, I was just thinking about, is if we put the people's email addresses in this presentation, we can send it out. Then that way they can, contact them directly if they have more detailed questions afterwards or think of anything too.
Definitely. We'll include that before we send it, for sure.
Okay. I think, and we've got Nora on to go next.
Hi, can you hear me?
Yes.
Great. So my name is Nora Quinn, and I am a program analyst. I work in systems redesign at Bay Pines in Florida. And I'm part of the Vision 8, which is kind of our region innovation work group. So we have been sharing different things that we're doing at our different facilities. So I'm in Bay Pines near St. Petersburg. We've got another facility in Tampa, West Palm Beach, so on and so forth. So a lot of places in Florida, including Puerto Rico, North Florida, South Georgia. So if you go to the next slide, one of the things we did here at Bay Pines, really very simple. We got together with our engineering group, and although the hospital has been severely reduced, the number of patients that we're seeing, we still have areas that are being trafficked by our staff and veterans that we service coming in. And one of those areas on the left-hand side is our urgent care area. So in our urgent care area, we would see there checking in would be any of our traveling veterans and also anybody who wasn't assigned to a primary care team.
That's great.
And of course, right now with Easter coming up this week, we are still in the peak time when we would have our traveling veterans here. Our snowbirds would have come down to Florida, and generally they're here from Thanksgiving all the way onwards till Easter. However, again, our population has been severely reduced. We are only seeing people in our urgent care and our emergency care, emergency room. All of our surgeries that are elective have all been cut out. So we have a much smaller population. But we stuck up these plexiglass shields there in order to protect the veterans coming in and the staff that are helping them. They can still push their documents and ID cards through underneath. And on the right-hand side, you'll see our pharmacy area. So our general pharmacy area where they would be getting their medication, that particular area is already a secure site. We have medicine that would be passed in a special drawer out to the patient. But this particular pharmacy window had the glass put up because we normally have a pharmacist here on duty that will be talking with our veterans, particularly if they have something new. They don't understand the medicine that they're getting. And now with COVID-19, there's been so many different things that are going on, and people are going home with items that they need to have a little bit of clarification. So we needed to put that up, and we've got 3 sections actually side by side where we now have pharmacists there that are working to help the veterans that we do have. Any questions on those? So that was a real simple fix. The second thing that we're doing, we are gearing up to do reprocessing of the N95 respirator masks using ultraviolet light. So at this time, we seem to have enough supplies on hand, again, for the limited amount of patients that we have and protecting our staff. However, we have a surge that is expected to come around April 21st, just estimated, and there is a concern that we are not going to be able to have enough PPE when this time rolls around. So we have been exploring what we would do if we needed to repurpose and reprocess those N95 respirator masks. So if you go to the next slide here, one of the things we would do is we have created these little bags that would have the mask in it. So this is what our providers will do. They'll take their used mask, they'll stick it into these brown bags. We have labels that will be adhered to the bag that each one of our services has been given, everyone who's still working with patients. Then once they are done, the mask is in there, we have red bins that we have located in our emergency room, in our surgery centers, in our patient rooms where we are caring for those patients that have tested positive. And they will deposit them in these bins, sanitize their hands, and then the provider is done. If you go to the next slide, this is then what our staff would be doing. So we have a sterile processing unit, 2 different types of masks that we have here at our facility. And what will happen is that they will, of course, be in the decontamination, going through the decontamination process in their sterilized area. The cups get held out on a clothesline, and then they, ensure that they're placed correctly, and then the process is going to start. If we go to the next slide. So as the disinfection takes place, there's of course nobody in the room. We have the Light Strike robot. It takes 5 minutes to go through this process, and then it's done. Next slide. So then the last part of this, of course, is repackaging and returning the respirators. So the respirators are now going to be placed in a white bag that is going to be returned to each of the providers. So on the bag, we had the labels that were there for the providers. So if John Smith used a mask, he would have that label on there. Additionally, on the mask would also be his name. So the two would go together, and they are now, the clean masks are put into the white bags. They are given that simple brown paper bag within the clean white bag that is sealed up, and then finally those respirators would then be returned to the units. So this is what we're gearing up for. We had to create the process. We have not been given the okay to do this yet, and our hope, of course, is that we wouldn't have to, that we would have enough PPE to get us through the surge, but in case we don't, we want to ensure that we have thought of the what if and what we can do with the items that we have on hand. Any questions on that?
Awesome. Thank you so much, Nora. That was really great and very interesting and relevant, I think, to everybody on the call.
Thank you so much.
With that, we're going to pass it off to Joyce so she can give an update on staffing productivity.
And I've unmuted you, Joyce.
Okay, thank you. Hi, everyone. Sorry I don't have any PowerPoint slides. I know we had a lot of discussion over the past couple weeks just kind of about staffing, and then also kind of leads a little bit into productivity. So I just wanted to kind of, give a brief update and certainly open it up to any other thoughts or questions. But I think, for those of us that are in healthcare organizations or in the hospital-based as well as outpatient-based services, we're experiencing a lot of unique changes and challenges. And just real quick, I'm based out of Northside Hospital in Atlanta, Georgia, and we have 5 not-for-profit community-based hospitals in addition to all of the outpatient services. So what we're having to try to figure out, and I know we talked about this previously, is that we have areas within our healthcare services that are either temporarily closed or not able to provide services. So we have kind of a downtick in our volume, as well as with our employees about what they're going to be doing. And then on the reverse side of it, in the hospitals themselves and in our urgent care centers, we have an uptick of the volume that we're seeing, based on the COVID patients and what we're having to do for them. And obviously, depending upon where you are in the U.S., where your surge is hitting or your peak is projected to hit, and how you're going to be able to handle that. So we've had a lot of involvement, at least, for the folks within kind of our healthcare labor management group, having to help with determining, where can we redeploy staff, where are they, what are their competencies, and where can we use them, and then how are we going to be able to meet the surge or the peak that we're expected to experience, and for how long. And so I thought one of the unique things that kind of came up this week that we were talking about, and maybe not so unique for folks that have been around for a while, but trying to figure out for the patients that are going to require critical care or ICU type of care, and knowing just within the nation right now, we're having a shortage of critical care staff, much less within the different states and kind of locally. So one of the things kind of our clinical folks have been talking about is being able to have that ICU or critical care nurse be able to help oversee some of our other nurses that may not have the full training that they've received from a critical care standpoint, but will be able to assist with the needs of those patients as we're expecting a surge. So I thought that was something that kind of, takes us back to maybe that team nursing concept that's been around in the past, but maybe not as much quite now. So anyway, I just thought that was unique, and I didn't know if anybody had any questions or other ideas that they wanted to share about what they're having to do with the staffing in their different organizations.
And so if you do want to contribute or have any thoughts about that or any questions for Joyce, again, you can either raise your hand or unmute yourself on the WebEx. Okay. Thank you, Joyce. Very interesting, especially timely with what's going on this week with the thoughts there. So at this point, we've got about 12 minutes left. If anyone has, as we've done in previous weeks, if anyone has other questions, either related to the topics that were presented on today or outside of that, that they'd like to ask a friend on this call, you're certainly welcome to do so now.
A question about the UV processing that was done. Is that only geared towards providers? And what is the capacity numbers we're talking about?
Can you restate your question? It was a little hard to hear you.
Sorry, yes. The UV light process, is that only just for the providers? And the other part to that was the capacity volume of the process.
Okay, so I think that would be for Nora. Let's see, I've got to unmute her. Hold on. There we go. Go ahead, Nora.
Hi there. So with the UV light process, it would, yes, typically only be for our providers. At this time, the number of staff that we have working in the hospital has also been reduced considerably. We have a number of people teleworking. So most of the people that are here, about 3/4 of them, are involved in direct patient care. The other quarter is doing the administrative work that is helping everything function, moving it through our incident command center. So most of those individuals would not need the N95 respirators. It would generally only be for those giving direct patient care. If things were to stay as they are, we're just fine. However, with the surge, we may not have enough, and that's why we were investigating this route for decontamination.
Thank you. Great answer. Thanks. Anyone else with any questions or related to these presentations or otherwise?
Hey, Erin, this is Val.
Hey.
I don't know if this question is for Nora or for anyone else, but it's regarding the N95 respirators. So one thing I learned is that we have quite a few in inventory. It's just that we don't have the right sizes, so we have a lot of the wrong size. One of our affiliates is using the wrong sizes, but using like double stick tape to create the seal around the mask. Has anyone had any luck or any kind of designs that they've used where maybe you could use a mask that doesn't fit by tape or anything else that would at least help create that seal that they need?
I've seen some different things around that space. People using any kind of rubber film, so to speak, so you can get that kind of fitting. Different other concepts like, you know, Vaseline perhaps to kind of close up on the sides, but when you got odd shaped faces, that becomes a different issue. And then we're often resulting to cappers. The other aspect is it's just repurposing employees that you don't pass an N95 fit test, then you cannot work on certain units that require that. And that's just for their own safety and protection. So our procedures and protocols are clearly defined when an N95 is in use. And if we have to repurpose individuals to other units, that's what we'll do.
Thank you.
Any other feedback on that question from Valerie? And it looked like Nora said in the chat, if you didn't see that, Val, but she's not heard of anything in Bay Pines yet. So, any other questions today or topics that anyone wants to discuss? We got about 7 minutes left.
Hi. Just wanted to comment on the last question relating to masks. Are you able to hear me?
Yes.
Hi, my name is Ernie. I'm an EMT by trade, but right now I'm a program manager in the Department of Clinical Transformation at Northwell Health in New York. I guess in terms of trying to get the masks to fit, what I've seen done with surgical masks particularly is to use a small pipe cleaner like they would use for arts and crafts to tape it on the inside to create a little bit of a ability to fold. But I believe somebody else mentioned earlier on that to modify the N95 mask, it's a little more difficult because there's fit testing. Mask is appropriate for the provider's face, and there are several different sizes and styles of N95 masks. So in order to ensure that full seal around both the nose and the mouth, it really needs to be done through a fit test.
Great, thank you. Thanks for chiming in. All right, if there aren't any other topics or any other comments, we can go and wrap up a couple minutes early. Get people to their Good Friday and their at-home Easter weekend celebration. So thank you all very much for being on today. Hopefully you got something out of it. We'll send out the slides afterwards. And we're including, as you can see, we're including email addresses to contact any of the presenters directly. If you have thoughts on something you'd like to present next week based on work that you're doing, please reach out to myself and Allie, and I'll be setting up, I'll go ahead and set up for next Friday, another one of these at 2 o'clock. So thank you all very much for joining, especially today on Good Friday. Have a great weekend. Thank you.